Welcome, everybody. Thank you so much for being here today. We are the Michigan Opioid Collaborative. My name is Joanna Smith. I'm a behavioral health consultant with MOC, and we're hosting the S.A.V.E. training, Suicide Assessment and Prevention, with our presenters, Jeremy Suttles and Matthew Rod. We'll get started in just a moment here, but before we do, I wanted to draw your attention to the QR code that's on the screen here. If you are claiming CMEs for today, there's the QR code, and there's also information at the bottom there on the right side of the screen that's showing how you can obtain your CME credits. If you're looking for McBAP credits and social work credits, I'll be posting a PDF in the chat with instructions on how to claim those. And you'll also be getting an email afterwards on obtaining credits from today and a follow-up from your local behavioral health consultant, who will just be touching base and providing the slides from today, as well as some additional information and materials that were shared. So before we get started, I did want to give an overview of what the Michigan Opioid Collaborative provides in terms of services. So we are a grant-funded program through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We provide same-day, all of our services are free, but one of our services is free same-day consultation services with our staff physicians and psychiatrists who specialize in medications for addiction treatment. So if you had any questions about treating a patient with any kind of addiction, feel free to give us a call and we can kind of help you through that process. We also offer support for clinical technical assistance, getting your office set up to be able to prescribe or treat different kinds of addiction disorders. We can also provide community resources if you needed assistance in connecting patients to mental health services, certain kinds of medications for addiction treatment in your area, and other kinds of community resources like clothing, food, shelter, that sort of thing. We have quarterly introduction to treating patients with buprenorphine trainings. We also have support for treating, diagnosing, and medication management for individuals with substance use disorders that are also pregnant or perinatal patients. And we also have services to assist in treating, diagnosing, and medication management for patients with hepatitis C. Additionally, we have support and education around non-opioid substance use disorders like webinars and toolkits that we've developed. And we offer a variety of monthly educational webinars on a bunch of different topics related to addiction and healthcare, many of them offering free CMEs, CEUs, and McBAP credits. So if you have any questions, feel free to reach out to us. Our administration email is at the bottom there. Like I said, your local behavioral health consultant will also reach out to you after today. And we'll go ahead and get started with the webinar. But before we do, I'm going to introduce our presenters today. So we're joined by Jeremy Suttles. Jeremy works as a community engagement and partnership coordinator at the VA Ann Arbor Healthcare System. He completed a bachelor's degree in English at the University of Iowa, a master's degree in education at the University of Kansas, and a master's of social work at the University of Michigan. He's worked both as an educator and a mental health clinician. His clinical experiences and interests include crisis intervention, suicide risk assessment, addiction and recovery care, outpatient mental health, emergency psychiatry services, acute inpatient psychiatric care, group therapy, trainee education, community education and training, and the treatment of adults and adolescents. He currently serves as part of the Department of Veteran Affairs Community-Based Interventions for Suicide Prevention Program. So this is the VA's public health approach to suicide prevention, combining clinical care with community partnerships to enhance suicide prevention and care. And we're also joined by Matthew Rod. Matt is a community education and partnership coordinator from the VA Ann Arbor Healthcare System. Matt graduated with his Master of Social Work degree in 2010 from the University of Michigan and has been working in the field since. Matthew has experience in several areas related to mental health, including practice as a substance use disorder therapist, mobile crisis clinician, assertive community treatment team leader, and suicide prevention case manager. Matthew has always seen the value in community partnerships while working on an individual level with patients, and now uses his clinical experience to help guide his community engagement work. So with that, I'm going to hand it over to Matt and Jeremy.
All right, Jeremy is going to be loading up our presentation here. So as he does that, I'll just take a minute to thank Joanna for such a kind introduction and also for the opportunity to present to everybody today. So thank you so much. My computer is acting a little funny, so I'm coming to you from my cell phone here, so I hope everybody can hear okay. We've opened it up for questions during the presentation, so feel free to either type a question in the chat or unmute, and we'll go ahead and answer them as we go. But we'll go ahead and start just to say welcome. Glad to be here with everybody, and certainly, be comfortable. We're all on Zoom, so it's lunchtime. I get it. If you're eating lunch or whatever the case may be, we hope we capture your attention to pay attention to this really important training. And this is a gatekeeper training, so many of us have probably been through similar gatekeeper trainings. There's a lot of them out there, and they're all really valuable. So this is just one of many. This is one that we like to present here on VA S.A.V.E. And this is going to hopefully give us just another tool in our tool belt, give us some practical strategies and how we can interact with somebody who may not be doing well, and how we can provide that person with some support and some help, along with maybe some resources too. So without further ado, we'll go ahead and get started. Jeremy, if you want to move to the next slide. All right, so this is going to sort of be our disclaimer for this training today. It's a heavy topic. Many of us have been impacted by suicide, whether it be personally or professionally. And I'm sure if I asked for, raise of hands, we'd probably see a lot of people that this has been very personal and near and dear to them. So we just want to say, as we go through this training, make sure if you need to step out or take a break or do whatever you need to do to take care of yourself, please feel free to do that. Chances are, as we're doing this training, we won't even notice because most of the cameras are up anyways, but I just want to make sure that you take care of yourself and know that the crisis line is also available, 988, or you can dial the longer number, 800-273-8255. And also just be aware of your local resources there close to your local CMHs or crisis lines. So totally want to put that out there just to make sure that we know to take care of ourselves and do what you got to do throughout this training. So why don't we switch to the next slide, Jeremy. And so our objectives today, we're going to look at some facts as it relates to suicide in the veteran population. We also kind of pepper these slides with some civilian statistics too in the adult population to kind of give some comparisons there. We'll go over some common myths and realities when it comes to suicide. And then we'll go over the most important part of this whole thing, which is the steps of S.A.V.E. And then leave you with some resources at the end here. Next slide. So once coming through, hopefully you guys will have a better understanding about the scope of veteran suicide within the United States. Also, again, the important part of knowing how to identify someone who may be at risk of suicide, what are the things to look for, and then what to do, when you've identified someone at risk and how you can provide that person with some support. And before we even get into the nuts and bolts of everything, if you got a pen and paper next to you, I really want you to think about what's your biggest question or concern around talking to someone about, having suicidal thoughts or someone who may be in a crisis. What are your biggest concerns or what are your biggest questions around that? And if you have some, write them down and we'll get to them towards the later part of the training. And we'll do some scenarios. So hopefully we may answer some of these questions as we go throughout the training, but if not, please write them down so we can get to them later. And today we're going to do something a little bit different than we're used to doing, at least for Jeremy and I. We're going to sort of alternate a little quicker between our presentations. So it's going to be me and Jeremy, and we're going to go back and forth. And so hopefully it'll keep us engaged. With that being said, I'm going to turn it over to Jeremy now so he can pick up on these next few slides.
Thanks, Matt. Just for some quick general information about suicide and its impact, just kind of a quick review. So, as I'm sure is not news to anyone here, suicide is a national public health issue with far-reaching impact. Historically, suicide rates have been on the rise here in the United States. But that being said, the numbers have declined actually in recent years, specifically from 2018 to 2020, which is some of our most recent data. Suicide rates are higher among the veteran population than the general population. which for Matt and I is relevant to our work at the VA and our specific outreach efforts. It's estimated that one suicide death impacts as many as 135 lives. And my guess is that many of you here have been impacted by suicide in some way, whether by the death of a loved one, surviving a suicide attempt yourself, or even knowing someone with current suicidal ideation. And though the numbers of suicides have decreased in recent years, the numbers still remain high, and one suicide death is too many. There is no single cause for why people die by suicide, which makes it hard when targeting our interventions and prevention strategies. Suicide is often the result of a multitude of factors, including individual and societal level factors that influence risk. And because there is no single cause of suicide, we must develop and implement a broad, dynamic approach to suicide prevention, which addresses risk and protective factors at all levels, starting with the individual person, to their community, to the nation, and to the world. At the VA, we do this through our combined public health approach to suicide prevention. Now, just for a quick review of risk factors and protective factors, risk factors are characteristics that are associated with an increased likelihood of suicidal behaviors. Some risk factors for suicide include prior suicide attempts, certain mental health conditions, access to lethal means, and stressful life events such as a divorce, job loss, or the death of a loved one. And on the other side of the risk coin, we have protective factors. Protective factors can often help offset risk factors. These are characteristics associated with decreased likelihood of suicidal behaviors. Some protective factors for suicide include access to mental health care, feeling connected to other people, and positive coping skills. While we're going along, so I won't be able to see the chat since I'm sharing my screen, but feel free to post additional risk and protective factors that you don't see listed here. This is actually a pretty short list, so not comprehensive. So if you know from your own practice or experience, feel free to share. And one factor that is common between both risk and protective factors is a sense of connectedness. If a person does not feel that they belong, it increases their risk of dying by suicide substantially. On the flip side, fostering that sense of connection and a sense of belonging is one of the strongest protective factors and interventions that we have.
All right, so not too long ago, roughly about a week or so ago, the VA dropped their 2022 National Veteran Suicide Prevention Annual Report. This is a report that can be found publicly. If you Google it, you will find that. If you Google this slide, this text here on the slide here, you'll find it pretty quick. So we had to kind of scramble a little bit and get some updated slides here because we wanted to be able to provide some updated information. This is released yearly by the VA, and I'm sure at some point we'll drop this in the chat as well too. But a couple things, we're not too keen on really wanting to talk about numbers. Every time we do, it's just one of those things where you look at a number and you just know that this can't in any way represent, what this truly means. When we look at suicide deaths and the number of suicide deaths, and like Jeremy mentioned, for each of these, roughly 135 other people are impacted. And that impact doesn't go away. It stays around quite a bit and for quite a while. So with that being said, I want to, just preface these statistics with that statement, because it's just important to know that one is too many, and we have a lot of work ahead of us. But let's move to the next slide. So this is showing veteran suicide death from 2001 to 2020, and where we see the last few years trending downward. It's definitely something we want to see, but again, there's a lot of work to be done. So to kind of take a quick look, roughly 6,100 veterans died by suicide. I'm sorry, 6,200, roughly 61 died by suicide in 2020, 61 in 2019, 61 comparative to 2018, you know, so veterans accounted for roughly 6,000 deaths in 2001, which represented about 20% of the suicides in the United States. But the data that we have now, by comparison, as far as 2018, we're looking at roughly 13.7% of suicides being represented by veterans in the United States as of the data, most recent data that we have. So that is quite a bit a difference there, from 20.2% of suicides in the United States being accounted for veterans down to 13.7%. What we don't show in this data, though, is, as many of us know, is that there's a tremendous uptick in overdose deaths, and the difficulty in identifying suicides when there's an overdose involved, when there's no overt messages or letters or things left there to identify what the intention of that death was, it remains unknown. So it's great to see these numbers trending down. Still much to do, and still a lot to do in the overdose prevention realm as well too. But these are the latest facts that we have right now, the most current data. If you want to go to the next slide, Jeremy. This is just kind of showing us the difference between veterans and non-veterans U.S. adult population. So as Jeremy mentioned, overall veterans are at a higher risk of suicide. And so what we're looking at here is just kind of the depiction there. So the teal colored is the non-veteran U.S. adult population, while the solid blue, dark blue color is the veteran population. And these are deaths per 100,000. So while, you know, the U.S. population hovers around anywhere 15 to 18, you know, we could see that, you know, veterans are roughly at about 1 to 1.5 times higher risk for dying by suicide compared to the non-veteran U.S. adult population. Let's move to the next slide, Jared. Okay, so this slide is just looking at the differences between male veterans and female veterans. Male veterans, you know, die at a greater rate compared to female veterans. So a couple things I do want to mention. In 2019, the adjusted suicide rates were 152% greater for veteran men than veteran women. The rates for veteran men were highest in 2018 and fell roughly about 3.8% in 2019. And the rates for veteran women were highest in 2017 at 19.9 per 100,000 and fell in 2018 to 18.1, and again in 2019 to 15.4, overall showing a roughly 15% decrease relative to 2018. So again, these numbers, you know, those things are going in the right directions, but this is so dependent on a lot of different things that it's hard to truly rejoice when there's so much more to do in this realm. Let's move to the next slide.
And that's me. And I promise we're almost through the data. I know it's a lot of heavy tables and numbers, even still, like early in the afternoon. This table indicates the suicide methods by which both veterans and the general population die by suicide. And you can see on this table that firearms are the highest, accounting for approximately 50% of all suicide deaths and over 71% of veteran suicide deaths. Firearms are used more often by men, but still at significantly high numbers among women. Suffocation and poisoning are the next highest means by which people die by suicide, followed by other methods, which may include motor vehicle accidents, falls, or others. This data is a state data sheet for Michigan related to suicide deaths and suicide means. I know probably on your screens this is pretty hard to see due to the size. But this informational sheet is available at the link that I posted in the chat, along with the National Suicide Prevention Report. And it's available for download and sharing. Of note from the sheet, there were 1,396 suicide deaths in Michigan in 2020, and 178 of those were veterans. So for the veterans, they account for about 13% of all suicide deaths in Michigan. But veterans are only about 6% of the Michigan adult population. So again, for Matt and I, this is relevant to our work, but hopefully something that we can plant a seed in your minds as you go forward in your community practice. Now we're going to talk briefly about lethal means safety. As you saw in the previous slides, there are various methods by which people die by suicide, and the most lethal of which is firearms. Firearms are lethal in about 85 to 90% of all suicide attempts, while all other methods combined are lethal about 5% of the time. When we're talking about lethal means safety, we're talking about a voluntary practice that individuals can engage in to limit their access to lethal means during times of crisis. Lethal means safety counseling is the process of having conversations about means safety with individuals, taking into account their values, preferences, and their own generated solutions. Because the goal of lethal means safety is to build time and distance between a person and their lethal means.
Jeremy,
yeah.
I'm so sorry. We did get a question in the chat about some of the data that you had shared.
Yeah.
They're wondering, is there any data that shows post-COVID rates or any information maybe post-2020?
So in the data that we have and our verified data, it goes up through 2020. I know some of the national data shows some different and interesting data from the perspective of the pandemic. In general, the suicide rates seem to have gone down among the general population, but up among adolescents, particularly like adolescents of color. We also have seen significant increase in firearm ownership during the pandemic, but we don't have those slides or those numbers here in the presentation because they haven't been VA verified. Usually our data is about 2 years behind. And we also don't have data available from our end on suicide risk associated with acquiring COVID, like if you have had COVID, how that increases or impacts your suicide risk or suicide rate. Good question.
Okay, thank you so much.
Yeah, absolutely. Thanks for bringing it up. So with regards to lethal means safety, building in time and space between the impulse to act saves lives. The majority of suicidal crises are brief, and you can see here from the picture on the left of the chart that the time between when a person has a thought of suicide and the time when they take action is often very short, with the majority of suicide attempts occurring within that first hour. So if we can help people get through that initial crisis, get through that period of time where the intensity peaks, we can help keep more people safe. However, if a person has access to lethal means during that initial crisis, they're at significantly increased risk of dying by suicide. It's also important to note that when we reduce access or remove access to one lethal means or one means of suicide in general, it's very rare for someone to switch to an alternate method. So the take-home message, again, is time plus distance saves lives. Lethal means safety works. It's actually, in the realm of suicide prevention, it's rare to be excited about, some of the work and some of the things that we do, but we are excited about lethal means safety because we have evidence that it does the job. In 1997, Australia instituted stricter gun safety measures, including minimum age restrictions, psychological evaluations, background checks, and waiting periods. And the firearm suicide rate steadily declined for about 4 or 5% each year following. And the researchers since then have not seen a substitution effect with other methods. And the firearm suicide rate continues to decline since that time. In Israel, military service is required for both men and women. Males serve for 3 years, females for 2 years. And in 2006, following a year of significantly increased suicide deaths by service members, the Israeli Defense Force instituted a program where service members were not allowed to take their firearms off base over the weekend. At that time, approximately 84% of all suicide deaths were via firearm. The Israeli Defense Force saw a 40% reduction in the suicide rate among soldiers when it restricted their access to firearms during weekend leave. So significant, almost by half. So this is exciting in terms of what we know about lethal means safety and lethal means safety counseling. Back to Matt.
Thanks, Jerry. So when, what are we saying? We're saying that there are things we can do to keep people's environments safe that can really make a difference. And this is powerful because a lot of times, people feel helpless in how to help somebody to really truly stay safe in a time of crisis. And lethal means safety is really a method by which we can do something. And when we say, suicide can be prevented, we mean that. And it goes along with the philosophy that it's also, on top of that, everybody's business. I think a lot of times by default, we're sort of conditioned to think that, anything mental health related should be, taken care of through a mental health professional or a doctor or anybody along those lines. And the truth of the matter is we really all have a role to play, and who better, depending which role we're operating in, than the person closest to that person, or as the person who maybe someone has confided in us with regarding how they're doing. So suicide can be prevented. It is, not a guarantee, of course, and there are times where there's maybe no ways to stop something like that from happening. But there are things that we can do, and we want to put that message out there. So we'll kind of kick it off now, getting into more of what I think to be the more important part, which is actually talking about things we can do to have an impact on this. So let's start out by talking about some common myths versus realities when it comes to suicide and suicide prevention and the whole kit and caboodle. So one of the most common myths out there is that, people who talk about suicide are really just seeking attention. And that is a myth. It's a big one. The reality is far different. No matter, in our world, no matter, in what context it comes up, we always take it seriously and kind of explore it and see if there's anything behind any of those statements, because that could be a cry for help. And if someone's crying for help, we need to answer that. So no matter how casually or jokingly said, take those statements seriously. And we'll kind of get more into this as we go through the signs and what to look for. But, someone who brings that up, if someone brings up the topic of suicide or brings up anything that raises some flags in our head, it's really an opportunity. We need to look at it like that. It's an opportunity to connect with somebody. It's an opportunity to explore and to see how they're doing, and be a support to them. So that one's definitely a myth. Let's move to the next one here. So the only one who can really help someone who is suicidal is a mental health counselor or a therapist. I'd probably go as far as to say, maybe we're some of the last people, to help somebody. And if you think about it, we are oftentimes the last people that get word of it. By the time a counselor or a doctor or someone else is getting this information from somebody, chances are they've probably reached out to other people. They've maybe talked to clergy. They've maybe talked to family. They've talked to friends. So no, we are definitely not the only people who can help. That one is certainly a myth. You don't need any special training. Things like this help. But, just being there for somebody is really what's most important. Giving some honest and genuine support can really, really, really go a long way when someone's going through a challenging time. And you don't need to be trained in social work to know that. So let's move to the next one. And I think, let me see, Jeremy, I think you're up here with steps to S.A.V.E.
So now we're going to get into the specific steps of VA S.A.V.E., which is the VA Suicide Prevention Gatekeeper Protocol. While it was originally developed working with veterans, and I know we've been talking a lot about veteran data, the training and the model itself is applicable in all settings and similar to other gatekeeper interventions that you already may be familiar with, like QPR or Living Works Assist. Suicide Gatekeeper training is about creating a wider network of helpers in the community to address suicide and suicide prevention. Think of it like being trained in first aid or CPR. The more people who have the knowledge and skills to intervene, the more opportunities we have to help. The VA's model is designed to be simple and easy to remember with the acronym you see here. S stands for signs of suicide. A is for asking the question. V is for validating the person's response and experience. And E is for encouraging and expediting help. So the first step is the S, identifying the signs of suicidal thinking. So this slide lists a few signs of suicide to be on the lookout for, such as feelings of hopelessness, risk-taking behavior, or withdrawing from friends and family. But again, just like when we're talking about risk factors and protective factors, this list is not all inclusive. So if you can think of other signs of suicide that you've learned from your personal practice or your life, feel free to post them in the chat for the benefit of others. Some warning signs that we really want to be on the lookout for are any indications that the person is having active thoughts of suicide or about ending their life. If a person is researching a plan, getting access to means, talking actively about death or dying, giving away possessions, or engaging in other concerning behaviors, it means that it's time to intervene and act.
And that's where really this next part comes in. So the A in S.A.V.E. is about asking the question, and that question is directly asking if somebody is having thoughts of suicide. Are you having thoughts of killing yourself? Are you having thoughts of taking your life? Very difficult question to ask sometimes, especially if it's not something that you do every single day. But I just want to say a few things on this. One, there's also this myth out there that if you ask somebody about that, maybe you're going to plant that thought into their head if they weren't originally thinking about it. And to kind of debunk this, I like to take the opposite approach, right? If you were talking to a friend and that friend was complaining about the traffic that they encountered on the way to work, and you said, man, don't feel like killing somebody sometime or something along those lines, my guess is that person is not going to, say, wow, I guess I never thought of that. Maybe I should, start road raging with people on the way to work instead, So same goes with suicide. By talking about it or asking about it, it is certainly not going to all of a sudden create this urge, desire, or thought to act on it. So it's a pretty safe bet to ask that question. And I always say that before the big A here of asking, it starts first off with approaching the person to have this conversation to begin with. The little A is approach. So if you've seen the signs and you've noticed some warning signs or some risk factors that are there and you want to check in on somebody, you have to approach them. It has to be intentional. And then at some point in that conversation, we definitely want to ask this question. So a few suggestions. Naturally, because, if you're like me and have a bit of anxiety, there's going to sort of be this natural inclination to want to rephrase this question. It almost happens automatically without any effort. I wish other things happened automatically without as much effort, but this one unfortunately happens a lot. And we may say something like, are you having any thoughts of hurting yourself? And while our intentions are good there, that's a pretty blurry question because people who self-harm, perhaps in a non-suicidal way, may answer this yes, and it kind of may be a bit confusing. So we always want to ask the question directly. And we want to phrase it in a way where people aren't going to be sort of led to say no. And what I mean by that is we don't want to ask the question in this way. We don't want to say, hey, Jim, you're not thinking of suicide, are you? Because it's really, one, showing we're not comfortable. Two, they're going to pick up on that right away. And three, they're probably not going to give you an honest answer because they don't either want to burden you with that information, especially if they're already feeling as if they're a burden to others, or they won't feel comfortable in answering that question honestly. So while we can't, control everything, we can control, how we sort of present this and the way that we ask. And I just also want to say, there's lots of things that get in the way of this one, but, don't also let, any type of fear of like that person getting mad at you stop you from asking that question either. Out of the hundreds, if not more times that I've asked this question to people, I don't think I've ever had a single person get upset with me because at the end of the day, they recognize you care, you're reaching out, and honestly, who doesn't want that, And so I think no matter what respect we're engaging with people on, whether it's personally or professionally, we need to ask this question because if somebody is struggling with that thought, that gives us an opportunity to intervene. So definitely one that we want to make sure that we're doing accurately as best as we can. So I want to sort of open this up. What are some people's thoughts about asking the question? I'll just throw this out there real quick too before you guys get your questions ready if you have any. One way I like to ask this, and I'm just going to leave this with you. You can take it or leave it. But the one way I really like to ask the question is directly asking if somebody's had thoughts of taking their life. Have you had thoughts of taking your life? And I personally like that one because it's a direct way to ask about suicide without using the word suicide, which does carry weight with it. So this is just a suggestion, but do people have any questions about asking the question, about what to do if the person says yes, or if they say no? I want to open that up for just a minute. They're being too easy on us, Jeremy.
I don't have any questions, Matt, but I would just echo that when I've done the same thing and asking people directly, it does have.
Hello.
Oh, hello.
Mm-hmm.
Oh, sorry about that. Yeah, I would just say that I've also always been met with positivity as opposed to people getting upset with me asking the question. People do tend to recognize that it's you being concerned for their safety and appreciate that.
Does look like maybe Carrie has a question.
Yeah, I was just going to add, if you ask somebody if they're thinking of taking their life and they say no, like I think it'd be easy to jump in and be like, oh, shoot, I don't know what the right answer is there, like how to act, because they might not be thinking of taking their life, but they've got all of these warning signs and behaviors and things like that. I don't think the topic's completely off the table either. So I just was curious as to so if they say yes or if they say no, what should our response be then? Like if they say no, I'm not, then you just kind of move on to the next question. Okay.
Yeah, no, that's a great question, because our worries or our concerns don't just disappear, like you said, like right off the bat there. You probably will still have concerns, but if you do, if I mean, here's a suggestion I'd say: if you do have that concern, and that happens a lot, maybe that person isn't having any thoughts of suicide, but you may know, like, oh my gosh, if this doesn't get better, if this doesn't change, maybe eventually that could come, and first of all, I think the fact that you're having that conversation with that person hopefully is a sign that they're confiding in you and that they trust you and they know you're a safe person to talk to about that. And let me just say that there's probably not many people in that person's life that they have that relationship with or feel comfortable with. So you've already now shown that person, I'm safe. The second thing is that could lead to them reaching back at you and say, hey, you know what? If you ever do feel that way, it's totally normal. Lots of people have those thoughts, and that doesn't mean there's anything wrong with you. It's actually quite normal, and I'm happy to be here for you and talk to you if you need it. Plus, by the way, if I'm sleeping and it's 4 a.m. and I don't hear my phone ringing, you can call 988 and press 1, and there's always going to be somebody there. Press 1 if they're a veteran, but if not, 988, and then there'll always be somebody there. Plus, by the way, up the street is, our community mental health. And if you ever want some help getting connected there or feel like that would be helpful, I lean on me and I'll help make some calls or do whatever I can to help you with that. So we want to leave them with, options. And what I'll say is always don't promise anything you can't deliver. And what I mean by that is if you're having that conversation, you're still concerned, say, hey, how about I call you tomorrow and see how you're doing? Would it be okay if I give you a call the day after tomorrow or tomorrow? We all have the tendency of saying, call me if you need anything, right? But, how often does that happen? Most of us don't feel like bothering somebody, right? That's just the way it is. But we need to ask if it's okay, ask permission to call, and then follow up. Make sure we do what we say and we say what we do when it comes to that. That would be the best suggestion I would have in that case where we still have some concerns.
That's so helpful. Thank you, Matthew. And I agree, like transitioning from the response into just following up with resources just in case, or like something about the future, or you maybe don't trust their response. So that is perfect. Thank you.
Yeah.
And I'll jump in before I move on, if it's okay, Matt, and just say, like, one of the things that's also worked for me in the past in the settings that I've been in is You know, to respond with something like, wow, you haven't? Like, I mean, I've talked to other people in this situation before, and people who've had less going on, and I know that they've had those thoughts. I mean, I might even imagine having those thoughts myself. And, you know, what's prevented you from having those thoughts? What do you think has kept those thoughts out of your mind while you've been facing all of this stress? And kind of getting them to sort of defend their point and have that conversation initially of like, what are those protective factors? You know, maybe I'm misreading the signs, and I will even say that, like, maybe I'm off base, but, you know, I'm still concerned. So help me understand. And giving them a chance to have that conversation has been helpful for me, at least in the settings that I've been in.
Thanks, Jeremy.
Yeah, absolutely. Moving on to the V, which is validating the veteran's experience or the person's experience. You know, this is essentially responding to the person sharing of their suicidal thoughts and being supportive of their situation and their feelings. And sometimes this can actually be hard for us as people because we may have our own reaction to what they're saying. And in some cases, a tendency to judge the person's thoughts about suicide and the reasons for ending their life. But it's important to avoid statements that sound critical or judgmental. Things like, oh man, I can't believe you'd be so stupid. Or that's a ridiculous reason to kill yourself. We want to be calm, be patient, listen, and respond with empathy and compassion. So I'll kind of move through like the exercise piece because I know we've got stuff coming up, but, you know, just think to yourself, what would be an example of a validating response if someone were to say, you know, they were thinking about suicide? You know, some examples that we might include would be, you know, anyone in your situation would feel that way. Of course, you feel overwhelmed. You have been struggling with a lot. And some invalidating responses might be like, you have a family, like, that's stupid. Why would you do that? You know, I can't believe that you would ever do something like this. You're so much stronger than this. You know, anything that invalidates the pain that they're experiencing. Validating responses show not only compassion and understanding for the person, but they also help build that connection between the person with thoughts of suicide and the person looking to help. And that connection can help move to the next steps for intervention. Yeah.
Yep. And next up, once we have that conversation, you know, hopefully that person, if needed, is open to getting some additional support or help or resources. And so that's really what this last step is all about, encouraging treatment and expediting getting help. How do we encourage somebody to get treatment? You know, I think taking the approach of, you know, oftentimes in our field, we're always talking about the problems and the problems and the problems. And sometimes we lose sight of sort of the solution focused end of it, or even the recovery portion of it. So what I'm trying to say, which I'm probably not doing a good job of, is how do we encourage people to get treatment is try to help focus the conversation on recovery. You know, lots of people, you know, hey, lots of people are going through things that you've been through. And I know this is unique to you. And nobody knows exactly what you're going through, but, you know, treatment does help, and people do feel better when they do that, generally speaking. You know, so I think it's important to keep the focus of recovery there. Let people know that help is available, resources are available. And then how do we actually expedite somebody getting help? What role can we play in doing that? And what I would say is, you know, being that person to, you know, hey, you know, you've got a lot on your plate. You've got all this going on, which is causing all this stress. And how about, you know, how would it be if maybe you let me take care of a few phone calls for you? Maybe I can call your PCP on your behalf, or maybe even with you because of HIPAA, and see what we can do about maybe getting you in to see somebody or talk to someone. You know, keep all those promises realistic. Follow through with what your, you know, with what your plan is. You know, reassure them that help is there and it's available. And then, you know, make sure that if somebody really divulges something significant and it's a safety concern, make sure you let them know, like, you know, realistic expectations. You know, if somebody discloses that, you know, they plan to take their life after their, you know, kid's graduation next week, and they don't want you to say anything, we have to be realistic with that too. You know, and they can be mad, but, you know, but you want to be open and upfront about it and say, as much as I would want to keep this, I mean, I care about you and I can't keep this a secret. You know, what should we do next to try to get some help? If somebody discloses that they're suicidal to you and you're with them in person, one key thing is not to leave them alone. Make sure that until you both have a plan that everyone's on board with, do not leave that person alone. Stay with them until you have it figured out. And if you get stuck and you're having this conversation, you know, that's a great time to get the crisis line involved. Call 988. And if they're a veteran, press 1, and they will help you problem solve right then and there on the spot of what to do. You can let them know the circumstance. And as another add-on to that, you know, always phrase these things in the form of a question. Don't, you know, let's not like pick up the phone or secretly call 911 or, you know, always ask for permission. And that's really empowering, because maybe at a time where somebody does not feel in control of their life or their circumstances, now, just in this conversation, we're feeding them some ways that they can have control. And what I mean by that is, how would it be if we did this? How would it be if we did that? Would it be okay if? And that person's now in the driver's seat making some choices, which helps a bit too. So definitely in our roles, we try to connect people and do so appropriately. And if it's anything super urgent or emergent, you know, nearest urgent care, doctor's office or hospital, or crisis walk-in center at a CMH perhaps, are all great places to go to get some support if it's urgent. All right, did I miss anything here, or did I leave anything out from this slide here? Okay, I think that should cover it. Let's get into the next part here. So, you know, getting back and piggybacking off the validation, this is all pretty straightforward stuff. Just recognize a few things. One, it's not about us. So whatever we're feeling in that moment, in that conversation, let it sort of just roll over. This is about that person. So we don't want to be argumentative. We don't want to interject our thoughts into whatever it is, or even interject our solutions, depending on what it is. Because if you're like me, sometimes the natural reaction is to want to interject with a solution to someone's problem. That's not always the right time, you know? So I've learned that lesson many times, and so hopefully you can avoid that pitfall. Be honest about everything that you're mentioning or offering. You definitely want to, you know, make sure that you follow through with what you're saying. So this stuff's all pretty straightforward, but we definitely want to mention it. Try to listen more than you speak. Be mindful of what that person is saying, and try to take a step back and just be there for that person until you feel it's right to reflect some of that back to them. Next slide. All right. So now let's say we're not with somebody, and let's say we are on a phone call and somebody indicates that they're having some suicidal thoughts. And this was in the slide, in a previous slide, but I'll just say this. If we're acting in a professional manner, I just want you guys to know, don't let any of what we're presenting today interfere or supersede any of your own policies or procedures that you may have through your own agency. So with that disclaimer out of the way, I've never found any of this stuff we're talking about to interfere, but just as a heads up, because we may have protocols for what to do in these situations at work. So it's important to know that. But if somebody expresses suicidal thoughts during a call, keep them on the line, keep them talking, engage, explore, be curious. You know, do not hang up on them or transfer them, stay on the phone, and do your best to stay calm as well too. Anything you can to, you know, identify at some point, you know, where they're at, or, you know, what's going on would be helpful, especially if we do need to call for a welfare check. You can always get the Veterans Crisis Line involved or loop them into the call as well too. But, you know, the one thing to keep in mind is that, you know, not every suicidal crisis requires the immediate attention of first responders. So while that option is there, we definitely don't want to rush to that as the go-to protocol. So, you know, that could actually end up doing more harm than not if it's used when it's not appropriate. But, you know, when in doubt, you know, talk to other people, try to loop in the crisis line, because they'll also be able to provide some support, coworkers, supervisors. You know, definitely get them involved if you can to try to figure out what's the best method or route to go. If somebody, let's say, discloses that they're suicidal and then hangs up the phone and they're not answering and they're not, returning calls, and you have some immediate concerns about their safety, that's the time to call 911 and request a welfare check. That could be done anytime, anywhere. And even if you don't have the address, if you have the person's phone number, they sometimes can use that to locate where somebody is, to check on their welfare. So they send a peace officer out to check on their welfare. They're not in trouble. They're not getting arrested. If somebody does require that urgent care, then they end up being brought to probably their local hospital where they have a mental health evaluation and go from there. Any questions about any of this so far?
We did get a question from somebody saying that we have limited counselors in the rural area that we live. I'm a home visitor and I only see them monthly. So if they answered yes to the question about suicide, what might be some good next steps for an area that might be limited in their in what they can offer?
Yeah, that's a great question. So the area of which you're at, there's limited counseling and limited resources. So, when it comes to part E, the last part of encouraging someone to get help, I would maybe say, if we're limited in resources, then what are other things that we can put in place? Are there self-help groups? Are there online programs that we could connect with? Are there online support groups that we could explore with that person and try to get connected with? Anything, it doesn't always have to be that professional support there for somebody to get what they need. That can be found in many times now online as well too. And I realize it's not ideal, but it is better than nothing. And there are a lot of offerings of support and resources online for lots of different things. So that could be an option. I'm not sure. I hope I'm answering that entirely correct, because I'm not sure if that question was also geared at, well, where would that person go if they needed that urgent care, or if it was more like, hey, we don't have a lot of, ton of counselors around. What are some other support areas for people? So that's the way I answered it, and I hope that's the way you were asking it.
I would also add in that too, take this opportunity now, maybe after this training, to, whether it's your work phone or your personal phone, add in some resources, add in the local community mental health, look that up for your county, your area, put their crisis line number in your phone, the 988 number, get a sense of the areas that you serve, the clients that you serve, what are the closest emergency rooms that might be available. Ultimately what we want you to do is never practice without a net, because, we don't want you to feel like everything is all on you in that moment. Like if you don't do something, if you don't immediately solve the problem, they're going to be unsafe. So there are a lot of great ongoing resources that Matt talked about, but just like with this training, we're hopefully giving you the information now before the next crisis happens. Hopefully between now and the time that you're having that next interaction, you can arm yourself with some of those resources. And if you're having trouble getting connected to some of those or need some assistance, feel free to reach out either to your colleagues or to us at the VA, and we can help identify some of those for maybe those future situations.
Yeah. And then,
we got a couple. Sorry, go ahead.
No, please go for it.
I was just going to say we had a couple of the questions in the chat. Another one is, do you have any additional suggestions on how to handle suicidal patients who are drunk or high at the time and it's difficult to have a straightforward conversation with them?
Yeah, that one's always challenging. And, I'll just jump in, Jeremy. So my time in doing emergency department screenings for inpatient psychiatric placements or diversions, that one comes up often a lot. Some hospitals, some places have, if we're speaking professionally in our professional role, a lot of places may even have procedures for that. So if someone comes in and, with an alcohol intoxication, they may wait till they're at 0.08 before they screen for inpatient hospitalization. And there's lots of things about that. But the fact of the matter is, we have to take what people say seriously. And regardless of where they are at, as far as their acute intoxication, we got to treat it as if it is exactly the way they say it is. You know, even if we may think that it is, that may be influenced, you know, by whatever substance they may be on. But if this is a hospital setting, you know, sometimes there's, you know, procedures about that. I know the hospital I worked at had a procedure like that in place. And that's always difficult, and it's always you know, challenging to get accurate information in that situation. Now, if we're talking outside and somebody's intoxicated, and this is a person who you're seeing in their home or out in the community, I would have some I might have some bigger concerns about that and their safety. And again, kind of going back to S.A.V.E., don't leave that situation unless there's a safety concern, but don't leave that situation until you both are on board with a plan that everybody can agree with. So whether that's, you know, hey, let's go to the warm, you know, whatever it may be, the warm shelter and hang out for a bit, or get you connected here, or, you know, what are some options there? So it's always tricky. There's not a great answer for it. At least I don't have a great answer, but that's usually how it's, you know, generally approached. In my experience, I've always, you know, you always just got to kind of meet them where they're at and do the best you can, and you know, and make the best clinical decision that you can, depending on which realm you're operating, whether as a clinician or personally. But definitely stick to what we've said. You know, if you're with them, don't leave them alone. Stick with them until you come up with a plan. Vice versa, if it's on the phone, you know, I would probably say more of the welfare checks I've ever called in were likely somebody that had some intoxication, which puts somebody at a higher risk for suicide. So always take it seriously. I hope that answered that okay.
Thank you. Yeah, and last question here in the chat. Does the 998 line offer that same guidance to resources? So I think that's just asking, do they offer resources or guidance to resources?
For sure. Yeah, 988 is connected into the local resources in the community there. They may not have everything, but they will have all the more common ones, you know. So similar to kind of like United Way's got, you know, an abundance of resources when you call them, and local knowledge of, you know, places and you know, things you know that are available. So does 988, very similar in that manner. So they have that capacity. When we're talking about veterans, any veteran, just so you guys know, when they call, let's say they call 988 and they press 1 because they're a family member or friend of a veteran, when that call goes through and gets routed to the crisis center that takes the call, there's an additional follow-up. So let's say somebody in Ann Arbor, and then our VA suicide prevention coordinators get notified of that call, and within 24 hours, 24 hours as far as a business day goes, then there's a follow-up. If that person requires immediate help, then immediate help's dispatched. But if it's not immediate, like I said, a lot of times suicidal crises are not always, you know, or suicidal thoughts are not always, you know, needing an immediate type of intervention, but that gets followed up within 24 hours on the local level with that person by our coordinators. Whether or not they're connected to benefits or whatever, they're getting calls and getting checked on. So just a heads up at that.
Thank you so much.
So I think we had, we were optimistic that we'd have time to kind of go through a scenario, but because of time, that's not going to happen. But we just wanted to maybe ask if there were any questions from anything that we've kind of presented or put out there today. We'd be happy to answer those.
So I'll keep this open right now, but for those that have to take off, I just wanted to thank everybody for coming and being part of the discussion today. You will be followed up with an email from your local behavioral health consultant, as well as an email about obtaining credits from today. But I'll go ahead and keep this open for the next few minutes. If anybody has any questions, we'll be happy to stay on and discuss those.
This is Aaron, and I'm with United Community Addiction Network. And so, you know, I work with people who struggle with substance use disorder. So obviously our worlds collide at some point, right? So that's the reason for my attending. I'm just wondering, I know it's SUD specific, but if a veteran calls and it needs help, are they available to go to any treatment facility, or does the VA and the insurances that they carry dictate where they go and when they can go?
All right, I'll jump in. So if you're working with a veteran and they are in any kind of crisis, you know, where they're in a suicidal crisis and they're looking for support or help, they can walk into any VA medical center and get that help, regardless of whatever kind of benefits they have or don't have. So with that being said, you know, we also have like little offices that are called community-based outpatient clinics. They're just like outpatient offices scattered around our medical facilities. People could go there as well too, and they would eventually get to the medical center where they can be further assessed. But yeah, so VA benefits and things like that are always changing and always expanding as the direction it goes. So just a few years back, they opened it up so that regardless of if someone served and they're in a crisis, they can come in and get help at no cost, period. So they do have that option. Hope that answered your question.
Specifically for substance use disorder?
No, that would be to address their crisis, their suicidal thoughts or suicidal crises, and there would be some continued follow-up of that. But as far as substance use disorder treatment, then you'd kind of be getting into the eligibility part of that, where somebody would then have to either apply or see if they're eligible for benefits to get that treatment at the VA specifically.
Okay, thank you.
Yep.
Yeah, because we do offer a full spectrum of substance use care, everything from like inpatient, outpatient detox to intensive outpatient to residential, you know, that kind of full spectrum care. And they can do some of that initial, like under the initial phase of getting people evaluated, but some of that ongoing treatment would definitely have to be enrolled and connected, and we can help them with that process, especially if they do come through the emergency room to get started, but they just may not be able to get all the services day one.
Okay, great. And then, so is that something that they would start by calling the 988 number and say, or is that not the intended purpose of 988?
Probably the best thing, if they're looking for those services, they could call the VA, their local VA directly, and start with the eligibility department if they're not already enrolled, and they can connect to the right department, whether it's the substance use disorders clinic or primary care mental health, whatever seems the most appropriate as that initial intake point. You can call 988. It's just going to be one little extra step that you'll call 988. It'll get referred to the local suicide prevention team. And then the suicide prevention team will call and follow up with that veteran and help make the connection. But you know, if you go to veteranscrisisline.net, you can pull up the local resources to find the closest VA to wherever that person is based on city or zip code, and then give them that number so that they can call and start the process.
Excellent, thanks.
So it looks like we got something in the chat. Sometimes clients are anxious about calling a crisis line affiliated with police services if they're using illicit substances. Do you have any suggestions about crisis services that won't call the local police?
I will say that 988 typically does not call the police unless there's an immediate safety concern. They will not notify law enforcement unless there's an immediate need to do a welfare check. The hope is that those crisis teams or those police and law enforcement are informed, and you know, recovery-oriented systems of care and might be able to respond appropriately without the immediately jumping to a charge. It's not always the case. Sometimes your local community mental health crisis team can also do that outreach and work in a way to be therapeutic versus punitive. But there's really no sort of guarantee that you're not going to be able to avoid that when you call. You know, you can, if you're able to call with the person and express some of the concerns and highlight the important needs right now, that can sometimes help. But in general, if you call 988, they're not going to notify law enforcement unless there's an immediate safety concern needing transport or intervention.
Mm-hmm. Yeah, and that's a great question. So yeah, they would never call the police out of just somebody disclosing that they're using illicit substances. So one, I'll just clear that part up, even if that wasn't what you were asking, but just to clarify, and like Jeremy said, to piggyback off what he said exactly, that the only time they will do that is when there is an immediate you know, safety concern. And it's not, even when people disclose they're suicidal, that doesn't mean an immediate safety concern. you know, they take these calls every day. So they really do know where that line is and when it's time to do that. But they again, they use that as a last resort because they don't want, because people, they know, you know, people don't want, you know, law enforcement or people showing up the doorsteps when it's not necessary. So, you know, that is a concern that we've heard before. And just, you know, make sure that your client knows, by the way, this is what to expect. And, you know, and that, you know, there's nothing wrong in telling them, like, you know, if you're worried about them sending the police out, the only time they'll do that is if this, and this, you know, and there's nothing wrong with letting them know that. I've had that conversation plenty of times.
Thanks so much, Matt and Jeremy. I am going to wrap it up just because I want to be conscious of everybody's time, but thank you so much for doing this presentation today and for sharing this information. It was really informative. And if anybody has any questions, feel free to follow up with your local behavioral health consultant who will email you after this. You can also contact Jeremy or Matt directly. They did post their emails in the chat, or you can follow up with me afterwards. So thank you so much for everybody's time, and please be in touch if you have any questions.
Thanks, Joanna.